Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Kristen Rosenthal. Today's episode features an insightful interview between a gynecologic oncologist and a patient advocate on how healthcare providers can partner with Black patients to improve the diagnosis and management of endometrial cancer. We are pleased to have Dr. Leslie Boyd, a gynecologic oncologist who serves as the director of the Division of Gynecologic Oncology and vice chair of gynecology for the Department of Obstetrics and Gynecology at NYU Langone Health, and Adrienne Moore, a patient advocate, survivor of endometrial cancer, and president of ECANA, the Endometrial Cancer Action Network for African Americans. This episode is part of a larger educational program titled Heightening Awareness of New Data and the Patient Experience to Optimize Endometrial Cancer Care. For more information on the experts, along with a link to the complete program, including downloadable slide sets, text modules, and a decision support tool for both healthcare providers and patients, please visit the show notes for this episode. Now, let's get started to hear what the experts have to say.
Hi, I'm Leslie Boyd. I'm a gynecologic oncologist at NYU Langone Health. I'm the director of the Division of Gynecologic Oncology there and the vice chair of gynecology for the Department of Obstetrics and Gynecology.
My name is Adrienne Moore, and I was a respiratory therapist for 22 years before being diagnosed with stage 3 endometrial cancer in 2016. But currently, I work as the director of peer support for women in active treatment for endometrial cancer on the sister study with Dr. Kimmy Dole.
Great, Adrienne. It is so wonderful to have you here and to be able to talk to you about this. So thank you for your time.
Thank you. I appreciate you having me.
So I wanted to start a little bit just with some background information on endometrial cancer. So endometrial cancer is quite common. It's the fourth most common cancer that women in the United States will be diagnosed with, and approximately 66,000 women in 2023 will be diagnosed with endometrial cancer based on our best estimates. It is one of the few cancers where our survival is actually declining. So despite all of the innovations that is happening throughout cancer care now with personalized medicine and immunotherapy, we are still seeing surprisingly poor outcomes for our patients with endometrial cancer. And that is because there is an increase in higher risk endometrial cancers that are being diagnosed. So endometrial cancers can be either low risk or high risk, to be simplistic. And unfortunately, Black women are far more likely to be diagnosed with these high risk subtypes of endometrial cancers. These are specifically uterine serous and clear cell cancers. They're also more likely to be diagnosed with advanced stage cancers, and that's including low and high risk cancers. And the survival of Black women, unfortunately, they are 2.5 times more likely to die of their endometrial cancer than white women. Just terrible. There are lots of potential reasons why this is. We think predominant reason is delays in care. Right. Yes. So not getting diagnosed early enough, not getting treated early enough, delays of treatment once diagnosis is happening. So we've got a lot to talk about today.
Yes, we do.
Absolutely. So I think most of the people tuning in understand this background. And I think, Adrienne, that's why your input is so critical here, because we need to know what we can do as physicians who treat these cancers, who treat these women. How can we improve our care? How can we advocate better for our patients of color? So in that vein, I would ask you to share a little bit about your personal story and how were you diagnosed?
Yes, thank you, Leslie. And I can appreciate all the background you've given. And these numbers are so scary, and they do sting a little bit to know that this information that wasn't given to me even before my diagnosis and when I was symptomatic. So this is just so very important that everyone understands how urgent it is that we start telling women earlier about whether or not they are truly experiencing symptoms of endometrial cancer or some type of precancerous condition, as opposed to just dismissing their symptoms as being normal. I think that's probably what a lot of Black women have experienced. Personally, for me, I was diagnosed in 2016, and I said it was stage 3C diagnosis, and it was almost a year and a half of just very intermittent, unpredictable menstrual cycles. And I should preface this by saying that I had a history already of ovarian cancer in 2003. So when these things were happening and I was going to see my doctors regularly, I was being told that I was probably perimenopausal because of the chemotherapy I received for this earlier cancer. I was also told that I had some symptoms of HPV. I had fibroids. I had ovarian cysts. I had everything other than anything that looked like what could be the beginning stages of an endometrial cancer. In fact, I had never heard of it, and no one ever spoke it to me. No care provider had. And it was during a time in 2015 when I lost my health care insurance that it got extremely, extremely bad. And I began to pay out of pocket to have more further diagnostic tests that people told me that I would need in order for them to get a really clear picture of what was going on. And that was mostly a transvaginal ultrasound. Never ever once was it mentioned to me that I need to have a biopsy. Never heard the word biopsy before. So I paid for those ultrasounds, and each one of them came back as, oh yeah, there's a fibroid. Oh yeah, there's a cyst. And I did that, more than a couple of times in 2015. And I remember lamenting to my primary care provider. And I said, I don't know what to do anymore because, I really don't know what to expect from my cycle. Sometimes it comes, sometimes it doesn't. It's so unpredictable. And then when it does, it's so heavy and it hurts so bad, it incapacitates me. And he said, go to the emergency room. They have to treat you. Well, if we recall, maybe in 2015 was right at the beginning of the Affordable Health Care Act, when employers had the option to have their employees, if they had a less than however many number, go into the marketplace. And that's where I was. I was in the marketplace. And trying to get care there was very expensive. It was, for me, after taxes, as a single person with no dependents, was well into $700 a month. So I've literally had to make a decision about whether or not I wanted to pay my my mortgage, or lose my house, or pay for health insurance. And I went without. That was the worst mistake I could have made, because in March of 2016, actually, I was on my way to a new job interview that was going to give me health insurance on the first day. That was March 2016. And the benefits person called me that day while I was on my way to orientation to enroll me. And I said, give me everything. I need to be covered. And that very next day, Leslie, I began to bleed, and I didn't stop bleeding up until the 2 weeks that it took me to get to see the specialist.
Wow. So, Adrienne, just to summarize, how many months were in between the time that you started really thinking that your bleeding was abnormal to when you finally saw a specialist?
I will say that my bleeding became probably abnormal by the time I was 35. I had finished treatment for ovarian cancer when I was 32. And about the time I was 35 is when I started seeing changes in my menstrual cycle that just made them a little bit more unpredictable. They weren't really heavy. I didn't have any really bad clots that, made me suspicious. They weren't painful. So it just around the time when I was, I guess I would say about 43, is when I think I really started to notice, oh, there's something just doesn't feel right. And that's when I started to seek the help of, specialists or basically just my regular OBGYN. And I would give them this background and my history and tell them, I think something's wrong. I had cancer. My father died of colon cancer. Should I be worried? Should I be concerned? And the answer was always, this is normal for Black women to have these type of periods. It's normal for Black women to have fibroids. So you're not experiencing anything that would give us any cause for alarm. And I was confident in what I was being told and just really naive in my ignorance of the other cancers that I was at risk for. And I wish that someone had told me sooner that I might be experiencing symptoms that would lead me to a different gynecological cancer than the one that I had experienced before.
Adrienne, how were you ultimately treated?
I was treated with surgery, complete hysterectomy. I received 6 rounds of carbotaxol, and I did them at different times because I had an allergic reaction to the Taxol. And then I was recommended for 30 rounds of pelvic radiation and then 6 rounds of brachytherapy. I will say I did a little bit of research and I got a second opinion. And the next radiologist told me, well, I think we could just do about 30 rounds of pelvic. And you shouldn't need brachy because of where the cancer had stopped. So I did complete the 6 rounds of chemo, but I was only able to complete 21 rounds of radiation due to side effects that had me in multiple hospitalizations.
And how long ago was that?
That was in 2016.
Wow, that's amazing. Can you talk a little bit about what it was like to establish a relationship with your treatment team after having been put off for so long from getting a diagnosis?
It was different because these were not the same people. Someone asked me before, did you go back to any of those doctors and tell them, look, you guys were wrong? And I said, oh, no, that wouldn't serve any purpose. And they said, but it might make you feel good, that it wasn't all in your head. But my new care team was now a team of an oncologist and an oncology nurse and chemo infusion nurses, and then my primary care provider who's always been supportive of me. So I would say that my relationship with my oncologist was very black and white. He knew what he knew. He was going to do what he was going to do. And didn't have a horrible bedside manner or anything like that. He's just an expert in his field. And so that he didn't mince words with me. He was this is serious. This is what we have to do. And this is how we're going to do it. My nurse oncologist was very sweet, gave me her home number, which I called several times. And many times she picked up and sometimes I had to leave a message. But overall, I think that the treatment of me personally was good and sufficient because I'm still here. I don't feel like I was ignored at all for any of the symptomatic things or any of the side effect things that I was experiencing during treatment. My doctor was the first person to tell me, you need to go to the hospital. And he was also the first person to tell me when he declared me NED that I didn't think you were going to make it. And that was probably the most sensitive time, or the most, I should say, I don't know how you say, like, people like not friendly is the most like warmest thing he probably said to me the whole time. And you worry, you wonder, like, okay, do you have to have this shield on? Like, I'm not going to get close to this person because I don't know if they're not going to be here, because obviously Leslie, he didn't think I was going to make it. I'm sorry, that's not very funny.
No, but I think that's real. So thank you so much for sharing all of that. And I think you're right. I think plenty of doctors hold back in the kind of emotional part of the relationship because it's hard to get attached to a patient and have them succumb to their disease. So I think what you experienced, and so, but I'm so grateful that you're here and you're here to tell us all about this and for your honesty and candor about all this. So thank you. This is a gift. Adrienne, I'd like to pivot a little bit. Can you talk a little bit from the vantage point of a patient advocate and tell us what we need to know, how we need to improve as care providers for women of color?
Yeah, I think the biggest hurdle for all of us is the one that sees Black women as fragile and valuable enough to put forth a little bit more effort into investigating where in fact their symptoms are born from. Oftentimes there's no real sense of alarm when we present with these early signs and symptoms, as you alluded to, which is one of the reasons for us having the worst prognosis is the delay in care. Because we're coming and we're telling you that this is happening and you're saying, okay, this is normal, but we'll see what happens in 3 months. Or when you come back in 3 months, if you come back in 3 months, if you have money to come back in 3 months, if you have time off of work to come back in 3 months to make appointment with my nurse, and then or the front desk, and we'll discuss it then, or 6 months. And I think to myself, how many 3 months and 6 months did I have left in me before anyone was going to say, this is a problem now, right? It's not a problem that's going to wait for 3 months. It's not a problem that's going to wait for 6 months. So I think that's the most that we just need to learn. We might just need to just go the extra step and say, okay, how's your period? No, really, how's your period? Because, there's this thing that's killing Black women, and I just don't want you to be one of them.
Thank you for that. I think that's very powerful. So just to rephrase, sounds like providers need to do a better job talking about menstrual history, talking about abnormal bleeding, and then following up on that talk and getting ultrasounds, getting biopsies, and intervening earlier. Does that sound right?
That sounds exactly right. I think it's okay for providers to come into a room and say, hey, here's a list. This is what, you wrote down what your issues are with your period. So this is what we're going to discuss. I'm glad to hear about your grandchildren and everything else. And then do it while they still have their clothes on. So it's not an intimidating time. We talk a lot about just building trust in any healthy relationship takes time, but at best, it's going to save lives. And not at best, what we wanted to do is save lives and save Black women's lives, particularly from this disease.
Adrienne, you mentioned, talking about these issues before you're undressed for the exam, when people feel vulnerable and exposed. Any other pointers you think? I like that. I think that's very concrete and something, that we can genuinely change in our practice. Any other pointers like that you'd like to provide us with?
I would just say, to provide the best care takes a full team effort. And we talk about who's on your care team a lot in the sister study. Yeah, you're on your care team. Patients are on their own care team. And we want them to know that it's okay for them to share and disclose everything they need to their gynecologist. And it's for their good. Nothing is private. There's a difference between something being private and something being pertinent. And when you go in there and before you undress and before you feel vulnerable, and this is what we teach our women or talk to women about in Econa, is that before you become vulnerable, have your armor on, have the things that make you comfortable, put that paper in front of you, all the questions you want to ask. All those things help doctors to know that you are entrusting in them what they need to know from you in order to provide you with the best care.
Yeah, and I think, Adrienne, that's the second time you've mentioned kind of having your list of symptoms or issues. And I think you're right. That is a standard practice for us to have patients fill these out, but we may not be following up on them to the degree that we could. And so that's another thing I think to take away from this, to make sure that, when someone comes in with a series of complaints that we take the time to listen and make sure that we follow through with them.
Yes, thank you. And I just really think it's important that we just alert a patient that she is at risk for endometrial cancer when she first starts experiencing symptoms. And this is not a wait and see kind of disease, because we've been waiting and seeing what it's doing to Black women for, is it decades now? I'm not sure, Leslie. I'm not good with data, but I know in 2016, I wasn't aware of these stark statistics. It wasn't until I met with Dr. Dole that I realized what a precarious situation that I was in. So don't be afraid to tell us what we don't want to hear.
Yeah, another great point. I think, the gravity of some of these diagnoses has to be disclosed to the patient.
Yes.
Yeah, because otherwise, how can the patient cannot partner with you and agree to this very intense treatment, right? Not just surgery, but, chemotherapy and radiation.
Mm-hmm.
These are significant, life-changing medical decisions. And so
Yes.
you have to have all the data to make the right decisions there.
You do. You have to have all the information. And it might seem like a lot, but we will listen. We will take it to heart, whether or not we listen that day, or we just go and talk to somebody or go and do a little bit of research. Eventually, we'll come around to the fact, oh, this is important. It's something that I need to follow up on. And you just want to make sure that you encourage her to do whatever it takes to take care of her reproductive health in the interim, whether she comes back in 3 months or 6 months or a year. And I say that because I know that not all women have the type of health care insurance that allows them to go to doctors regularly. But for the emotional health and the mental health of both the patient and the provider, it's just best that we just lay all of our cards out on the table and make sure that we are as clear and communicative as possible from the beginning. And that way, maybe we can get to have a better ending.
Again, great advice. And another thing you brought up a couple of times, Adrienne, as you alluded to kind of in your own story, and I'm sure you've heard in many other stories, the impact of your insurance status on whether or not you could follow up consistently. So I think that's another really important takeaway, that unfortunately, Black women are much more likely to come from kind of precarious financial situations. And so the lack of follow through at any given appointment should not be understood to imply a lack of seriousness or intent or desire to follow through. But sometimes there are barriers that are simply too great to get over.
Yes, there are. Unfortunately, there are a lot of gaps, and one of them is there's a health gap, and there's wealth gap, but then there's a service gap as well. We don't have some people in some communities don't have services that provide them with childcare that allows for them to take an extra half an hour after work or before work to be able to go to a doctor. And then the jobs that you have don't often allow you for a 2-hour lunch appointment to go to visit your gynecologist, who may have to be across town from even where you had to go to work from, just so you can make good enough money to afford the insurance that you have. So there are so many barriers that we have to consider that's keeping Black women from getting the care in the proper time that it needs to be gotten, and that's important to saving their lives. So I don't know how you address that. That's just the hugest barrier, and it's not something that's going to be solved in this conversation, but it's definitely something to be considered.
Yeah, you're right. These are really big questions and big problems, but I will say that this shines the light on the need for really empathy and flexibility, particularly for patients with color and all of our patients who are going through, particularly difficult social situations, because without that, then they are at a significant disadvantage, right? So having if you don't get to my appointment in 30 minutes, well, then, you're getting canceled today. That's certainly not going to be the way we improve outcomes.
Right. Thank you for bringing that up. Thank you, Leslie.
Adrienne, I want you to have the last word. So anything else you'd like to let our listeners know today?
I would just like to say I appreciate all the work that care providers do, that research and oncology does to make sure that they are staying, up on what's the latest and the greatest treatments are for this particular cancer. I know, and like I said, in 2014 or 16, nobody was talking about this. And now it's, endometrial cancer in Black women, it's like, it feels like a hot topic. And I am grateful for it, though, because it gives us all the opportunity to talk about have a very needed conversation right now. We can save lives right now. So that did you tell me in the beginning, 66,000 women will be diagnosed? So we can continue to cut that number down by year. So I'm grateful that we're talking about it, and let's keep talking about it as many times as we have to talk about it until we change everything about it.
Adrienne, this has been so delightful. Thank you so much for being here with us today, and thank you all for joining us today.
Thank you very much, Dr. Boyd and Ms. Moore, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Heightening Awareness of New Data and the Patient Experience to Optimize Endometrial Cancer Care, and to access additional resources associated with this program from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.